our colleagues. Not much for me to offer. Everything's said. But I will take you to a journey. The journey will, you move it from which corner here? Forward. Okay. Doesn't move. أيوة بس I would like to move. Okay, this one. Okay. Always ancient Egyptian history is fascinating. Burn is three catastrophes, not one. It's overwhelming trauma, it is financial trauma, it's psychological trauma, and the worst ever to happen to a human being is burn. Statement from Quran, وَبَدَّلْنَاهُمْ جُلُودًا غَيْرَ جُلُودِهِمْ. The Lord didn't say بدلنا عظامهم أو شيء آخر. The injury of the skin is heroic. Nothing to compare to any trauma, even a train crush you completely. Burn is more painful and more catastrophic. If you take a 30% burn, excise it, make it a surgical wound, and throw it away. Even in the first 30 minutes, end up with sequelae of burn completely for 3 months. That's the major effect of burn. I have another study added to the 818. I would like to show you that the majority of, in our part of the world, the children is very high incidence in the children compared to adults. Scald burn goes to the maximum number, flame 10%, electrical 4%, gas 3%, friction 4%, radiation 4%. Mortality in our group, I will summarize it. In spite it's very low, but even the 4 mortality you got, we are not responsible for them. Because when a child comes to the emergency room and die in the emergency room, we consider it our mortality. Actually, we didn't treat him because he transferred from another hospital after 3 weeks and he was in a miserable situation, dying. But I consider it my mortality. But I include it. Majority male 64, majority pediatric 69, majority scald injury 76, majority 10 to 20% burn. Breakthrough in burn management, it came in the last 20-25 years when hyperalimentation and the new antibiotic comes through. I add the third one, without sand bed or sand fluidized bed or air mattress bed, a patient like 90% you can save them. President Sadat visited us, so we had only the first 4 sand bed in the Middle East. He admired one, we gave it to him as a gift. He took it with him to his palace. But it's needed to save burn cases. Pediatric burn. In pediatric burn or burn in general, never promise anybody that the result will be this way or that way. Same patient, same treatment, same management, hypopigmentation, hyperpigmentation, normal healing. Never promise anything of healing of burn. Aesthetic surgery, we're not going to talk about it, but we'll go faster in this. When you refer a patient like this, who is resistant for all antibiotic on planet Earth, and can do except just take him to surgery and debride him and graft him, the maximum you can do. But if a patient like this, During the war, that's sulfuric bomb, but we end up healing him, even the chemical burn. That's his hand, and also can heal with skin graft. I'll talk about it later. The word skin graft is magic. Most of the textbook will tell you in some cases you have to do flap. I will show you the reverse, and I'm giving a message. Go to the textbook and change this chapter and say skin graft can be done everywhere in burn management or reconstruction. 65% burn. See the limited area of donor? It's only the right leg. Only the right leg is my donor area. But you can cover him completely with mesh graft. When it becomes over 100%, this picture, sorry, I have to comment on it. This picture won the first prize of Cairo University contest for photography. I took it for 3 successive years. My job is before plastic surgery was a photographer. 75% our graft came from the upper abdomen, 3 times from the same donor area and the skull to cover her body completely. But the disaster when it comes 95%. This patient, when I say 95%, he is 100% plus, because inhalation burn another 20 to 25%, then this patient 125%. Did you leave this patient according to the rule of 100, that's the age of the patient plus the percentage of burn, you're going to die? Fight with your patient. ومن أحياها فكأنما أحيا الناس جميعا. Fight for your patient. Then we'll take care of him. We intubate him, and during intubation in the 3rd week, 21 days, the anesthetist, I can't continue intubate this patient. Says why? Because of complication of intubation. I review all the literature at that time. It was 30 years old literature, and what we have now, silastic and intracheal tube and balloon, says, okay, that's an old complication of the old intracheal tube. We decide to continue intubating him. This patient was intubated 79 days. And after we awake him, no complication of trachea or all the list of intubated said in the last 30 years, no complication. We published this in the Journal of Anesthesia, July 1995. We make a history of intubated any patient in the ICU, bare or not bare, you can intubate the patient 79 days. This patient went home in 3 months and went back to take care of his family. Just a skin graft, then it was here. Sulfuric acid, a blind man want to clean himself, and he doesn't know it's sulfuric acid. He thought it's a water. He burned his penis, and this is grafted back to normality. Diabetic didn't feel the hot water can hurt her, but this is the worst area to graft. But you can tie over, and trauma, the same, burn and skin graft. Complication of burn. If a patient comes to you with the elbow attached to it, I present this in Salt Lake City, and this is every member of the committee said flap to the axilla, from the elbow to the lower chest. Skin graft, medium-sized skin graft, full function, the arm up in the sky. Breast, skin graft. Complete contracture, skin graft. Severe injury neglected for 6 months. I excise everything down to the peritoneum. If you left no scar, you get a good result. Skin graft, skin graft. Look at the skin quality, no flap. Severe injury, I never seen it before. The father put it on my desk and disappeared. I took the patient without consent. I signed the consent myself. He's attached from the ankle to the buttocks, but luckily it took 2.5 hours playing with him because the vascularity is extremely compromised when you release him. I end up divided the biceps tendon and straighten it up and graft him. And that's his result. Excision completely after compression, take it down to the peritoneum, no flap, only a skin graft. This is what we excise. This is how it looks. Hyperpigmentation, yes, function, 100% function. But if you left more scar on the tendon, just graft up to the peritoneum, and you will end up, the graft will take very well. You don't need a flap in this case. Severe scar contracture up to the distal forearm. Stage, to straighten it, the vascularity get compromised, but slowly take it step by step, but you end up in one session and the skin graft. We talk about hair transplant. For this lady, the eyebrow, I prefer this strip of full thickness skin graft with the hair. It gives you better than the bunch technique. I personally prefer it this way. In old days, I tried the bunch technique for burn patients, but nowadays we move to prepare it with the PRP. Tissue expansion is ideal in any traumatic hair loss, and this is the result. And this is also another result. I'll go faster because the Professor Adri promised me to do it on time. Hypertrophic scar, standard treatment, is well-known story. Keloid, you can inject them every 3 weeks after excision. Excise 3 times, but it came with the bigger one. But when you inject it continuously, during surgery and after surgery every 3 weeks, you get this result. Complication, it goes from hyperpigmentation, radiation, squamous cell, basal cell carcinoma, excise the whole back and graft. Marginal ulcer after 9 months, excise completely, include the cartilage, irradiated and completely covered with a skin graft, and heal completely, and after 2 years, calcification is common, and this is cautery, and the cautery is disastrous. It gives you marginal ulcer because cautery is a burn, and burn gives marginal ulcer. And in this case, we took even the bone and graft the brain. Bipedicle, I designed this, not only one pedicle, bipedicle across the whole skull. And this is give you excellent healing here and hair growth after the bipedicle. I'm sure I'll stop here, give Professor Adri 1 minute. Thank you.